is yours.
Thank you very much, Rainier. Thank you. So the purpose of DIAMONDS was to evaluate the clinical effectiveness and cost effectiveness of subthreshold micropulse laser when compared to standard laser for the treatment of patients with diabetic macular edema with central subfield thickness of less than 400 microns. DIAMONDS was a pragmatic and investigator-led, multi-center, allocation-concealed, randomized, equivalence, double-mask clinical trial, which was set in 16 specialized eye hospitals within the United Kingdom. The participants were people with diabetic macular edema that was central involving, but when the central retinal thickness was less than 400 microns. And these are some examples of patients enrolled in DIAMONDS. They were randomized 1-to-1 to receive either standard laser or subthreshold micropulse laser. The standard laser was done as per routine clinical practice. This was our standard of care arm, to which we compared the new treatment, which was subthreshold micropulse laser. We did it using a 577 nanometer wavelength laser. We did do titration, so what we did is we programmed the laser so that it was very easy for the investigators to touch upon the slot in the laser to do the test spot. And with that test spot, which was a single spot, we started with a power of 50 microvolts and then start increasing it at 10 intervals, so until we had a minimal response observed. And when that minimal response was seen, say that it was at 100 millivolts, then that was the threshold for the patient. Then the laser would be in micropulse mode, and then we'll go using 5% duty cycle, and that will be multiplied by 4. So if the 100 achieve a little area that you can see some effect, then we will times 4 and we'll use the 400. And that would be used for the whole treatment. We use 7x7 grids with no space in between the spots, which were placed 3 in one side of the fovea, 3 in the other side, 1 up above, 1 down below, at 500 microns from the center of the fovea. In the first treatment, subsequent treatments could go closer. The primary outcome of DIAMONDS was the mean change in best-corrected visual acuity from baseline to month 24. This was an equivalence trial. It's a special type of trials we can discuss if needed, but basically the secondary outcomes are very important in equivalence trials. And we have a secondary outcomes: binocular best-corrected visual acuity, central subfield thickness, mean deviation of the hand-free 10-2 visual field, proportion of people meeting driving standards, and this came directly from a patient and public involvement group, which was giving advice all the way through from the very conception of the trial until the trial was ended. The quality of life, visual acuity scores, QALYs gain, side effects, number of laser treatments received, and use of additional treatments, predominantly anti-VEGFs. DIAMONDS was powered as an equivalence trial, as I just mentioned. It had also power to determine whether there was no inferiority, obviously, but also superiority if there were to exist. And we required 113 participants per arm to see a powerful effect. And actually, even though this trial was done throughout the COVID pandemic, we were very pleased to see that over that number of participants that we require, we evaluated at month 24 when the primary outcome was measured. So we have 116 in the subthreshold micropulse laser arm, and we have 115 in the standard laser arm. Just to show you some baseline characteristics of the patients, the numbers are small, but just the highlights are the fact that these patients were the majority overweight, obese, and morbidly obese. These seem to be the people that developed diabetic macular edema in the UK, with a poorly metabolic control, HbA1c of 8.5%, and a slightly reduced visual acuity of 20/25, Snelling equivalent. Just preempting a question that I usually get when I present DIAMONDS: how do the population differ to that published by the DSR network in Protocol B, where they were different? You know, these patients had poorly controlled diabetes, had reduced vision. As you can see, we have a small percentage of people with 20/25 vision, whereas that was higher in the Protocol B. And the central retinal thickness was thicker in DIAMONDS compared to Protocol B. But additionally, one important thing that I want to mention is the equipoise. So, when investigators offer patients to be in a trial, the investigators need to have equipoise, which means that they are going to be happy whatever is the randomization, so they feel that the patients will do equally well at that stage when you are testing these treatments, whether they go in one arm or another arm. And of course, in Protocol B, one of the arms was observation, so the investigators need to feel comfortable that the patient will go into the observation arm and they will do equally well than in the treatment arm, and that was not the case in DIAMONDS. In DIAMONDS, the investigators felt that the patients needed treatment, and we randomized them to 2 different types of treatment. So what did we find? Well, we found that actually subthreshold micropulse laser was equivalent to standard laser. We set up the confidence intervals, we set up the different margin of equivalence to be plus minus 5 ETDRS letters, and the confidence intervals fall within those 5 ETDRS letters. These are examples of 2 patients that were treated within DIAMONDS in the standard laser arm and subthreshold micropulse laser arm at baseline and at the 2-year mark. And we didn't see any statistical significant differences in any of the outcomes, secondary outcomes that we investigated, with the exception of the number of laser treatments performed, which it was statistically significant, half a session more in 2 years. It might not be clinically relevant. And the number of laser treatments received during the 24 months was 2.4 sessions of subthreshold micropulse laser and 1.9 in the standard laser. Over 95% of participants fulfilled driving standards at month 24. That was the one that was very important to patients. That was the outcome that came from them. 9% still have a dropout of 10 letters or more, though, we need to remember that. 18% in the subthreshold micropulse laser arm and 21% in the standard laser arm receive at least 1 anti-VEGF injection throughout the 2 years of the trial. And importantly, the cost of this treatment, not the treatment, the whole package of care for the 2 years duration that these patients were on the trial, the whole treatment was less than £900 in the subthreshold micropulse laser arm and just over £1,000 in the standard laser arm. So in conclusion, subthreshold micropulse laser was found to be equivalent to standard laser for the treatment of patients with centrally involving diabetic macular edema with less than 400 microns central subfield thickness. It's an inexpensive and effective treatment, and certainly in my opinion, the patients are on their rights to know about this treatment and should be offered this treatment so that they can choose whether or not they would like to receive it. I'd like to thank all my collaborators and all the investigators that took part in, and all their teams with a great effort. I'd like to thank all the collaborators, trial steering committee, trial monitoring committee. I'd like to thank IDIDES, who provided the free loan for the lasers, but they were not involved in the trial in any way. This was an investigator-led trial, as I say, and I have no conflict of interest to present, by the way. And I really would like to thank the DIAMONDS Patient and Public Involvement Group, which is the group of patients that take part on our trials to provide advice on the design and which outcomes are important to them, and to all the DIAMONDS participants. And I'd like to thank you for your attention.
Thank you very much for the interesting study. So, of course, in the UK, you're formally not allowed to treat patients with anti-VEGF when the central subfield thickness is less than 400 microns. So what would you advise people outside the UK who are able to use anti-VEGF in those cases, how to use the results of your study?
So thank you very much for the question, Rainer. The National Institute for Health and Care Excellence does not recommend people to treat patients with diabetic macular edema of less than 400 microns with anti-VEGFs because and actually I think the DIAMONDS shows further this evidence, because the evidence demonstrates that laser treatment does equally well. And of course, the majority of patients would probably prefer it, and it's much less costly. But still people can treat, if they wish to, people with less than 400 microns with anti-VEGFs. And it still happens in UK. Whether or not that is the appropriate thing is a different thing. And I think that, again, I think that what is very important is that patients are informed. Patients have the right to be informed, and they are the ones that should choose. We should not choose for them.
Okay, of course. And another question, sorry. Did you have any evidence in your study that the micropulse laser was safer than the standard laser?
So we show that there's equivalent, and we didn't see changes in quality of life comparing the subthreshold micropulse laser with the standard laser. We did not look at the effects on producing RPE loss and retinal scarring in the retina, because, of course, work done already by Eduardo and many others have shown that, and that is very clear, that there's no damage that the subthreshold micropulse laser does in the retina. So that had been shown before. It was not planned to be investigated any further in diamonds.
Okay, thank you very much. Then I would like to introduce my esteemed co-chair, Professor Midena, who will explain us everything about drill.